and the surprise test as well. So testing the patient's right arm, we want to go ahead and have them in that abducted position, and I'm going to go ahead and stand here. So for the apprehension test, what we will do is I'm just going to be here and I'm going to passively provide external rotation to the arm. The patient would say at some point, oh, I feel like it's coming out, or I feel like some instability at that point of the joint. When I have that patient say that, that's going to be a positive point. That would be a positive test if I notice that it's before the proper range of motion. So if it was here at probably before like that 45 degrees, chief complaints of, oh, I feel like it's coming out forward. I come back out, that would be a positive test for the apprehension. Going straight into the relocation, I then provide a slight compression over that joint, go back into that test. I notice that she has an increase in range of motion and the chief complaint disappears. That's a positive test. Then from there, when I take away my hand, she says, oh my gosh, the pain went back, and she apprehends again. That's a positive test for the surprise test. And all of these are going to be for that anterior instability sensation. So this is going to be the sulcus sign test for multidirectional instability. So I'm going to feel for the acromion, and then from there I'm going to drop off where that sulcus sign is. From this point, the book says that you can go right below the elbow to pull down for that traction, but I saw in the video that you did above, right up below the distal humerus, so I'm just going to go ahead and do as such. So I'm going to go ahead and just pull some traction down, and you're feeling for that sulcus to be widened with a gap, and grade 1 is with it being 1 centimeter in distance, grade 2 is 2 centimeters in distance, and grade 3 is greater than 2 centimeters in distance for that to be a positive sign. This next test is going to be the load and shift. So what I do is find the acromion. I can go ahead and stabilize around that area. I find the head of the humerus with my opposite hand, and what I want to do is if I shift forward, I'm checking for that anterior instability, and if I shift posterior, I'm assessing for posterior instability. And if there's increased motion or if she has any chief complaints with either of those, that's going to be a positive sign. This is going to be called the jerk test for posterior instability. So I'm going to go ahead and have the patient's arm and shoulder flexion to 90 degrees, internally rotation. And then from here, I'm going to go ahead and stay on this side. So I'm going to have my hand stabilizing behind that scapula, and I'm going to go ahead and provide this posterior force while having them in horizontal adduction. And a positive test would be instability, chief complaints of that same response, or I could feel that shoulder going in that posterior direction excessively. So this next group of special tests is going to be the anterior drawer and the posterior drawer. So Alex is in the position for both tests. My stabilizing arm will be wrapped around the coracoid process through the spine of the scapula. Stabilizing. So to do the anterior drawer test, I'm going to go ahead and put my hand through the axilla, and I'm going to have my hands behind the head of the humerus so that I'm actually providing an anterior sensation. And a positive test for this would be that anterior laxity or chief complaints that she feels like her shoulder is coming out forward. So to do the posterior instability, same positioning, but my hand is now kind of wrapped more forward, and I'm pushing more of a anterior to posterior glide. And again, she'll say of that chief complaints of laxity behind the shoulder, or chief complaints if she feels like it's going to be coming out of the socket, and those will both be positive signs for instability. This next test will be the posterior apprehension test, and I have the patient supine testing the right shoulder. I put them in the plane of the scapula. From here, I'm going to have them in slight internal rotation. While I have them in internal rotation, I'm going to be providing an axial load to the arm. I can have my hand behind the shoulder, so when I feel that clunk, the patient would say I have some, again, that instability in the back of the shoulder. I feel like it's going to be popping out, the chief complaints, or I can even feel that laxity or that shoulder popping out a little bit more than the unaffected side. And that would be a positive test. This is going to be the Hawkins-Kennedy test for impingement on the supraspinatus. So with this test, I will go ahead and elevate the patient's arm to about 90 degrees of shoulder flexion. Then from here, provide that stability. I will then push down into internal rotation on the patient. Just remind them, just try and relax. I'm going to just give you some force. Depending on what their chief complaint is, they could have that response immediately. They could have a little bit of time to get that response. But a positive test is when they have that elicit of pain or that elicit of discomfort in that shoulder during that internal rotation passively done. This next group of exercise testing is the Zaslav's test. So I'm going to have the patient in this abducted position. I'm going to go ahead and provide the stability within this. So if I provide an external resistance force, and this one is weaker than the actual internal resisted force, that would be a positive sign that there was a pathology to the extracapular region, or potentially also being the rotator cuff. If the internal rotators were weaker than the external rotators, this lets me know that this is a potential intracapsular issue. And both of these would be good for us to know in regards to assessing what direction and where specific is that instability. This next test is called the Neer's impingement test. So I will have the patient seated, and what I will go ahead and do is passively, I can do, this test you can do in multiple ways. So I'm just going to go ahead and show it when there was a positive impingement for the supraspinatus, which is with internal rotation. So if I have the patient in abduction and I fully abduct the patient, full 180, and then I go ahead and make sure they're in that full internal rotation passively and they have chief complaints with that direction, this will be a positive test for impingement on the supraspinatus. You could also do it with in the external rotation to assess for that bicep tendon as well, if that one was positive with pain with the external rotation. But for supraspinatus specifically, within that internal rotation, and she has pain, that's a positive test. This is the supine impingement test. With patient supine, I'm going to now abduct the arm fully passively, and I want to make sure that they are in internal rotation while I provide this. And Alex has obviously a negative test because she is able to go full 180 without pain, but a positive test would be if there's pain in that internal rotation while I provide that abduction. This is the posterior impingement test. So what I will do is I'm going to bring the arm all the way up into this abducted position. While they get into this abducted position, I can then, when they get to that end range, provide an external rotation force. And the patient will then have a chief complaint of that shoulder pain below or just posterior to the shoulder when I'm providing that external rotation while they're in that full abducted phase. And that, again, is for those patients that are in that cocking phase, do that impingement behind the shoulder right before they go into that release. This is the O'Brien's test for a slap lesion. So with the patient, I'm going to have them in flexion, slight horizontal adduction, and I'm going to begin with them in this internal rotation. I'm going to apply some resistance. Do not let me hold, do not let me push you down. Then again, I'm going to maximally external rotate them and say, do not let me push you down. And a positive test would be if chief complaints were expressed when they were in that external rotation as compared to the internal rotation, or if she had any clicks, pops, again, chief complaints. This is the anterior slide test. So you have to instruct your patient that you want to have their hands on their hips with their thumbs pointing out. Make sure you stabilize around that clavicle and the scapula. So what I'm going to go ahead and do is I'm going to push the arm forward with some resistance. And a positive test would be that chief complaint of that pain in that right shoulder, or she could have that clicking or popping, again, in that same duration and location that she was explaining that she had come up with. This is the Kim's test. So I'm going to go ahead and get the patient in the proper positioning of some elbow flexion. And I want to make sure that I'm stabilizing around the elbow and the forearm, also the distal aspect of the humerus. So from this position, what I'm going to do is I'm going to provide a posterior to inferior force through the humerus while providing an axial load down that elbow. And a positive test would be that clicking, it would be that pain in that shoulder, or that instability kind of sensation that you could be having with that popping from that potential labral tear. This is the biceps load test for potential SLAP lesion. I will then put the patient in 90 degrees of abduction. And I want to make sure that she's in that supinated position, also supporting that distal humerus and the elbow. I will have the patient resist this motion. Don't let me move you. Good. And a positive test of this would be that clunk, that discomfort in that shoulder, or any type of feeling that that labrum is potentially involved from her chief complaints increasing. This is the clunk assessment test for labral pathology. So I will have patient raise up their arm. I will put my left hand in a fist, and I'll put it directly underneath that joint, the glenohumeral joint. From here, I will bring their arm into abduction. I'll make sure that their elbow is flexed, and I will have them in slight external rotation. I'm providing the external rotation force, and a positive test for this would be that increase in that clunk sensation, that increase or that apprehension that she feels, that grinding, and this would all be a positive test for that labral pathology. Next test is the crank test, and this is assessing for potential labral pathology. I will have the patient supine. I will have them in the scapular plane of about 160. From here, what I'll go ahead and do is I will flex the elbow. I want to provide an axial load to the arm through the humerus, and with that, I will then I will externally rotate the forearm, and I'll internally rotate such that of a crank. And with this, I'm applying that axial load. And a positive test would be that grinding, that clicking sensation in that arm, which would elicit potential pain and discomfort, causing a positive test. This is the resisted supination external rotation test for a potential SLAP lesion. With the patient in 90 degrees of abduction, I will instruct her that I'm going to go ahead and have you try and point your thumb all the way down in this position. You may feel me resisting this position. I'm going to be resisting you doing that. At the same time, I'm going to be moving you into this position. So let's do that again. Point your thumb down. I'm providing resistance, but I'm also bringing her into external rotation passively. A positive test with this would be the grinding in that shoulder, the clicking sensation, or any chief complaints of pain that she came in with. This is the Speeds test, and it's assessing for the biceps tendon. So I'm going to have the patient in shoulder flexion, making sure that they are first in that supinated position. You resist this motion, hold, don't let me move you. Then you go ahead and put them into the pronated position. Hold, don't let me move you. And a positive sign for this would be increased pain or increased chief complaints with the arm in that external rotation rather than the internal rotation. This is the Jorgensen's test for that biceps tendon issues or complications. So with this test, I will have the patient in 90 degrees of elbow flexion. With this, I will then ask the patient to be in a pronated position, and I'm going to have them supinate, and I'm going to resist that in addition to resisting external rotation motion. So go ahead and point your thumb all the way like you're trying to empty out something, and then I'm going to go ahead and ask you at the same time to move your arm out and go for it. So I'm resisting both of these motions. Come back together, do it again. And I have my hand over this tendon of the where the actual long head of the biceps tendon runs, right where that actual transverse humeral ligament would be. So one more time, resisting, and I'm feeling for if there's any excessive motion, if I'm feeling for any pain in that actual area, and that would be a positive test for this. Moving on to tests for the AC joint, I'm going to start with the crossover test. So I am going to go ahead and elevate the patient's arm, and then I'm going to go ahead and go into a horizontal adduction. I'm going to put some pressure over there, and a positive test would be if the patient expresses pain over the AC joint itself when I do that passive motion. This next test is called the anterior shear test, or the AC joint shear test. And what I will do is have my hands over the scapula, specifically the spinous scapula, and then my other hand will be over the deltoid. And they're going to be kind of crossing over each other, and the whole point is so that I can assume or create a shearing motion or a shearing force. And a positive test would be pain at that AC joint itself. This is the Paxinos test, and it's assessing for the AC joint. What I will do is have one of my fingers, so the thumb itself is going to be on that posterior acromion. So find the acromion itself, find that distal or the posterior aspect. My index finger will then be more towards around the clavicle on that middle aspect. So what I will do is kind of create like a pinching sensation so that it's kind of moving that acromion more forward, and I'm pushing the clavicle posterior. And what this would do is cause anterior shoulder pain if it was positive with that AC joint being affected. This is the external lag sign for rotator cuff pathology. I will have the patient bring their arm all the way up, and I will have them in an external rotated position. So with them in this abducted position and with them in this full external rotated position, I will then have them hold this degree. I'll let them know I'm going to be letting go, and I want you to hold this position, please. And if I let go, I'm looking for them to hold this, maintaining this isometric position. Positive test would be if you see them kind of losing control of that external rotation. This would be a positive sign for that. Next is the internal lag sign, and this is mostly focusing for that subscapularis, which is a part of the rotator cuff. I will put the patient into a position of deep internal rotation over the back. I will then elevate the arm, spacing it from the back, and I will have them hold this position, hold here, and do not move. And a positive test would be if there is an inability to hold that spacing, if I see how they go right back to the back, or there is a lack of control, and that would be a positive test for this. This is the hornblower special test for the rotator cuff pathology. Specifically, this is going to be for that teres minor. I will have the patient up in 90 degrees of the scapular plane. I will then apply a passive force into internal rotation, so she has to work that external rotator actively. And a positive test would be if she has weakness and she's unable to resist that force. This is the belly press special test, and this is again for rotator cuff pathology, isolating out that subscapularis muscle. So I will have the patient bring her arm into this position. With my hand going through, I'm going to say resist my motion. I'm going to go ahead and kind of push you forward. And what I'm doing is I'm kind of pushing her into this kind of external rotation, you want to say, and I'm trying to see if it's actually coming from that subscapularis, or if she's compensating with any motions from the wrist flexors, or if there's any compensations from that shoulder extension. And those compensations would be positive tests along with chief complaints of pain or any discomfort. This next test is called the drop arm assessment for rotator cuff pathology. What I will do is passively bring the patient's arm into 90 degrees of abduction. I will say, patient, I'm going to release your arm just very slowly, and you're going to have to hold it up. And I want you to hold it up with full control. Now what I would like you to do is slowly bring your arm right back down to your side. And I'm assessing the control of both of these things. So if she was unable to hold her arm once I let go, that's a positive. If she's unable to control the motion all the way down slowly, that's also a positive for these tests. This last test for rotator cuff pathology is the dropper sign. So what I will do is I will have the patient's arm by their side, and pretty much what they're doing is going to be in a 45 degrees of external rotation. I will then apply I will apply some resistance, pushing her into internal rotation, and she has to compensate for that. Excuse me, she has to resist that and go into external rotation. And a positive test for this would be weakness or an inability to do that actual motion or control the motion, or if there's any chief complaints of that pain in that shoulder. So I'm going to go ahead and start working on the mobilizations for the shoulder. So the first one I'm going to go ahead and show is the PA, a posterior glide to increase shoulder flexion. So with this, I'm going to go ahead and make sure that her arm is between my arm. She's nice and relaxed as much as possible. And I want to make sure that my hands are very, very close to one another. So I'm going to have this hand very close to the the proximal humerus, and then my obtural hand is going to be right over the capsule itself. So I know that if I want to do a grade 1, it's going to just be very, very light, grade 1, grade 2. Grade 2 will be a little bit bigger, but it's not going to be past. And if I want to do grade 3, it's going to be going past in bigger ranges all the way through that range of motion, and grade 4 is going to be at the end range and nice little small oscillations, I apologize. And again, this is to increase shoulder flexion. So that's going to be a PA glide. If I were to want to do an inferior glide, and this would be good for increasing shoulder abduction, I can keep her in this position with her hand underneath mine. But the most important thing with this is to make sure that I have this inferior force with my forearm. So it probably would be best for me to stand on this side. So I'm sorry if you can't see this. Let me go ahead and make sure the camera is facing the correct way. So again, I have her in this position as such, and I want to make sure that her arm is nice and relaxed. And I want to make sure that I have my arm in a position so it's in line with the force of pushing. So I'm going to have my hand right above that capsule, and I'm going to go ahead and start performing that glide. So remember, inferior glide, I'm going to be pushing down. So I'm going to go ahead and do my R1, which will just be very small. R2 will be bigger, but it's not past that range, that mid-range. If I want to do in grade 3, it's going to be bigger oscillations all the way through. And grade 4 is going to be little ambulations, making sure that I'm at that line of force. Your computer just shows. Alex, if you can come off the table just a little bit, please. So now I'm going to do my lateral glides, and let me go ahead and set the computer. Sorry, just a little bit better. So patient's arm is going to be out, and so we have different options of doing this. So because she is not a big linebacker, I have her arm by my body supported, and my hand is going to be closer to that axilla. So remember what we said in class is why work harder, let the body do all the work. So I'm just going to go ahead, and while I'm in this position, I'm just going to go ahead and slightly turn by using my body. And I'm just going to go ahead and hold and open that up. Let me do it again. Hold, and I can do maybe some oscillations at that 4 at that end range. And that's going to be for the lateral glide. And to do now the other glides that we were talking about, so we have, one of them was going to be flop the fish, and I can go ahead and show that one first. And we know that flop the fish is going to be good for increasing the range of motion. So I'll go ahead and set that one up. Grabbing the towel, grabbing some sheets, I'm going to have that overhead. And you know that you want to go ahead and first assess the range of motion for which the patient's limited in first. Set this baby up and move this back and forth, back and forth. So if Alex's range of motion was at, so go ahead here, and we'll say that this was her range of motion at this point, and she was only here. So at this point, I'm starting at this elevation because she had pain here. Lower her slightly to that point. Then I'm going to go ahead and set this up. So make sure the sheet is nice and secure. And I'm going to go ahead and get my positioning. Elbows nice and tight. And we're going to go ahead and start flapping. Making sure that it's in a nice rhythmic pattern. And we know that, like we said, that this is going to be good for increasing the range. I can go up a little bit more if the patient allows me to. I can go a little bit less, but we want to make sure we're getting a nice rhythmic pattern the whole time. Now we're going to go ahead and do the opposite one, which was row the boat. I'll move this opposite so that you're able to see that one as well. Now row the boat is going to be good for those grade 1, grade 2 for the pain modulation, as opposed to the first one, which we did was more of the grade 3, grade 4. So now we can release the sheets. We want to get them into this position where they're in that shoulder abduction, and we're holding them, securing them at the distal aspect of the wrist and then the, at the elbow. Make sure that you're nice and close, and you go ahead in a rhythmic pattern. That's the most important part. And then you go ahead and just continue.